Hello, everyone. Thank you for joining us today for our webinar entitled Staged for Success, Medicaid Promoting Interoperability Stage 3 in 2019. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will be posting the presentation slides and a recording of today's webinar on our website, www.mceda.org. Also, the presentation slides are currently available for download in the Handouts section of your GoToWebinar interface. Today, Bruce will provide you with an overview of the Medicaid Promoting Interoperability Program, reviewing core program rules, eligibility criteria, and 2019 program requirements. From there, Bruce will take a deeper dive into the Stage 3 objectives and measures and also review the new state requirements for electronic clinical quality measure reporting. Lastly, he will discuss some other items you need to know about to be successful in the program this year, provide some links to important program resources, and with any time left, he will address questions posed by the attendees. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining me this afternoon. Hopefully your day has been going well thus far. So we are going to jump right in and with the program basics. There we go. So I have a lot of information to cover. I tend to ramble on. There's so much information that I would like to convey, but it's pretty tough to get it all in an hour. So we're going to cruise through a lot of this. We'll start off with some of the basics for the Medicaid Promoting Interoperability Program. So one thing that we had is a name change. So about a year ago or so, CMS changed the name of what was previously known as meaningful use on the street. I think a lot of folks still use the meaningful use term, and I think it's still fine to do so, but it has gone from being called the EHR incentive programs to now the Medicaid Promoting Interoperability, or PI program. So very easy to confuse with some other programs out there. CMS has kind of grouped some different programs together and are kind of all calling them promoting interoperability, which is causing a little bit of confusion. So just a note here that this is not the QPP or MIPS Promoting Interoperability Performance category. That is a separate parallel program. The PI performance category under MIPS certainly originated, the objectives originated from the legacy Medicare Meaningful Use program, but these are very different programs now, especially this year in 2019. On the MIPS side, the PI performance category underwent a major overhaul. And so while there are still some similarities, they're vastly different programs. So the Medicaid PI program, otherwise known as Meaningful Use, is still scheduled to continue through 2021. And if you have not captured all of your incentives, there's still some good incentives to be had here. You can still earn $8,500 per provider per year through the end of the program. There are a total of 6 incentives in total. So counting that first AIU year, or Adopt, Implement, and Upgrade, where you got about a third of the total dollars. Following that, you can claim Meaningful Use or reach Meaningful Use for an additional 5 years. You did, however, have to start that participation no later than the 2016 program year. So if the provider or clinician had not at least put in for that first incentive, the AIU incentive, by 2016, they're not able to participate any longer in the program. But if you did throw your hat in the ring and have not captured all of those incentives, please keep going. There are significant dollars to be had. So one thing to note here, though, too, is the Medicaid PI program is completely voluntary. There are no penalties for not participating. There previously was a link between the Medicaid Meaningful Use program and the Medicare penalties that came as a function of that, now that is severed. So you do not get penalized on your Medicare reimbursements for not achieving Medicaid PI. You may, if you're duly eligible, find yourself needing to participate in the MIPS track or in the quality payment program to avoid penalties, but that does not play in here to this program that we're talking about today. Stage 3 is required in 2019 now. For several years, we have had the benefit of attesting to the much lower thresholds under modified Stage 2. But as of last year, modified Stage 2 is now sunsetted, and everybody is forced into doing Stage 3 for 2019 and through the rest of the program through 2021. As a function of that, you have to ensure that your EHR is upgraded as well to the 2015 edition certification. You cannot achieve Stage 3 requirements on the prior edition of your EHR, what was known as the 2014 certified version. So you have to be on 2015. There are a lot of vendors that are still trying to get certified for 2015. Some of them are certified, but they're still in the process of implementing 2015 across their whole client list. If you find yourself in that bucket, make sure that you communicate with your vendor. Ensure that at the very least, they've got you upgraded no later than October 3rd of 2019, as that would denote your last 90-day reporting period. There are some vendors that may find that they're still working on that certification. Excuse me. But if they're able to at least deploy that 2015 technology, that could be okay. Because as long as you're using the technology that they're still in the process of getting certified on day 1 of your reporting period, as long as the vendor achieves that certification with ONC, the Office of the National Coordinator, by the last day of your reporting period, you would still qualify for meaningful use. But you do have to ensure that you're using that version of your EHR for all 90 days of your minimum 90-day reporting period. We'll take a look at the program eligibility, looking at provider types. We haven't seen any changes in this at all, really, throughout the entire meaningful use program. So the same folks who have been eligible to participate are in prior years is still the same now and will remain the same throughout the end of the program. That includes medical doctors, doctors of osteopathic medicine, your dentists, optometrists, nurse practitioners, certified nurse midwives, and then some physician assistants. They have to be practicing in what's called a PA-led FQHC or PA-led rural health clinic, or RHC. You can determine that facility is led by a physician assistant in a few different ways that are bulleted out on the screen now. When the physician assistant is the clinical or medical director at that clinical site of practice, that would mean it is a PA-led facility, and those physician assistants, all of the PAs within that facility would then be eligible for meaningful use. If the PA is the owner of the rural health clinic, that would also call it PA-led. And it's really the third bullet that we see primarily the path that we see the most PAs qualifying. And that is when we can show that the PA is the primary provider in the clinical site of practice. And by primary provider, there's a couple of different ways that you can denote that. So when there is a part-time physician and a full-time PA, the PA will automatically be considered that primary provider. You're going to have to substantiate that through some sort of auditable data source. And then you can also look at your 90-day eligibility period and look at the total number of encounters over all of your clinicians. If at least one PA has more encounters during that 90-day eligibility reporting period, and I'll talk about that period in a moment, then all of the MDs and DOs in that same facility, then again, you would have a PA-led FQHC or PA-led rural health clinic. So really, you could look at vacation schedules even, and oftentimes when the MDs and DOs go on vacation, the PAs are there to pick up the slack and see all of those patients. Oftentimes, that means that during that 90-day period, the PA automatically ends up seeing more patients during that eligibility period. That's a good way to get your PAs on board in terms of eligibility. So again, as we've seen all throughout the program, on the Medicaid side of meaningful use, you have to demonstrate that a minimum 30% patient volume is attributable to encounters with Michigan Medicaid enrolled patients. It doesn't mean that you have billed Medicaid necessarily for all of those encounters. You just have to look at all of the patients that were seen in a 90-day period and look at what insurance they have. If they have Medicaid, and you have at least 30% of the patients seen during that 90-day period have Medicaid, then you are eligible to participate in the program. Pediatricians can qualify at a slightly lower patient volume of 20%, but just know that that means you will only receive 2/3 of the incentive payment. So you won't get that full $8,500 if you qualify at that lower level as a pediatrician. So even as a pediatrician, if you can qualify at the 30%, you definitely want to, because you're going to want to get the full incentive payment. And a little note here that the way the Medicaid program defines a pediatrician, mid-level providers don't qualify, unfortunately. So just be aware of that caveat. If you have mid-level providers and you are going to try and qualify for meaningful use using what's called group proxy or the group encounters method, and I'll touch on that, I think, on the next slide, your mid-level providers would not be able to participate in meaningful use at that 20% level. And then for those who practice predominantly in the FQHC or the RHC, they still have to achieve that minimum 30% patient volume, but they also get to include their needy individual encounters to reach that 30%. Needy individuals is defined in a couple of different ways. That would include the charity care encounters as well as the sliding fee scale encounters. And a little note there that My Child Encounters does not qualify as needy individual because all clinicians are able to include the My Child Encounters as part of their Medicaid encounter total. So we talked about that eligibility period just a moment ago. It's a continuous 90-day reporting period during which the eligible provider demonstrates that they have reached that minimum 30% Medicaid volume. So there's two different ways to find that workable 90-day period. Again, it has to be a continuous 90 days. You can look at prior 12 months. This option is defined as the prior 365 days from the date of EP attestation or registration. So for the 2019 program year, most of you are going to be logging in to the state system, into CHAMPS or EMIP as it's called, sometime in January, February, or March. Whatever day you find yourself logging in to complete that attestation, if you picked that prior 12 months, you would look at the 365 days behind the date that you're logging in to do that attestation. You also have the option of prior calendar year. So this option is defined as the calendar year prior to the program year participation. So for the 2019 program year, that would be anywhere in 2018. And so quick note here then that there is a strange caveat that happens, and there's really no way around it. Because of these two options and the way they work, once the attestation period opens, it creates what we call here at MCEDA a dead zone of unusable eligibility dates. So for example, as I have there, if attesting on 3/21/19, 1/1/18 through 3/20/18 is now neither prior 12 months nor prior calendar year. So just be aware of that. A lot of clients get caught up in that problem where they look at the first, like Q1, we have a lot of Medicaid patients come in during Q1 for their annual visits, but unfortunately, unless you're logging in early January, or as soon as you can, let's say January 3rd, most of Q1 is going to be out of reach in terms of that eligibility date, because if you log in near the end of that attestation period, in, let's say, even on April 1st, which would have been an option this year, all of Q1 was off the table for that eligibility date, which is unfortunate, again, because so many Medicaid patients, I know, come into your offices during Q1. So the way to avoid that is to log in as soon as you can in 2020, so that dead zone is as small as it can be, and you can then use those or most of that Q1 eligibility date. So as before, we have the two different ways to measure that eligibility as well. You can do it at the individual clinician level. So you look at just Dr. Bob's visits and determine that in that 90-day period, he saw more than 30, or at least 30% of his patients have Medicaid. You can also use this group proxy option. It's a great way to get more of your clinicians in the game here and be able to participate. Under the group proxy option, you are adding together all of the clinic's eligible patient volume and qualifying everybody with one single data set. So you get to define what the group is. Oftentimes you would do it either as all of your clinicians under the one tax ID, but you could also do it by group NPI, and some of the larger groups take advantage of that option as well, where they may be a large multi-specialty practice, but they've got these individual group NPIs, maybe perhaps broken up by specialty, let's say. So you could qualify folks individually or in groups of clinicians. You do have to use one methodology per year under your organization. So either all of your eligible providers or eligible professionals, as they're called in this program, either all of them use that group option or all of them use the individual option. You can't pick and choose there. So as I mentioned, looking at the actual program requirements, then we are locked into stage 3 requirements this year. We've had the benefit of a lot of delays in the program, where we've been able to achieve meaningful use using the little bit easier thresholds and measures, but now we are in stage 3. Stage 3 has 8 objectives with 20 associated measures, and I'm going to unpack those objectives and show you all of the measures in just a few minutes here. You have a minimum 90-day reporting period. Again, in the past there was some fear that we were going to be reporting a full 365 days of the objectives and measures. I don't know that that's actually going to happen now. By the looks of it, we are going to have 90-day reporting periods through the end of this program. That 90-day reporting period for your objectives and measures can be different from the eligibility reporting period, and it most often is, especially if you're using the prior calendar year option. That would mean your eligibility period is coming out of 90 days in 2018, but your objectives and measures, of course, have to be within a continuous 90-day period in 2019. And I did mention already that it does require that 2015 certified version of your EHR. We had a little bit of a change in the clinical quality measures. As of this year, CMS is trying to do some program alignment. There was a mismatch initially between the MIPS requirements under the quality category there and what folks were reporting under the Meaningful Use program. They have now aligned those. So the Medicaid PI program now matches the MIPS requirements, where when you are reporting on 6 clinically relevant electronic clinical quality measures, one of them must be an outcome measure, and if no applicable outcome measure is available, you can report on one high priority measure instead. And if no clinically relevant outcome or high priority measures are available to you, you can report on any 6 relevant ECQMs. If you have reported or if you've attested to meaningful use in the past, you are locked into a full year of reporting. But if you have never achieved meaningful use in the past, meaning you've never actually attested to the actual meaningful use requirements, so that first incentive, the AIU, adopt, implement, and upgrade, doesn't count for this. But if you've never achieved meaningful use, and there are still some providers out there, you have a minimum 90-day reporting period for those CQMs as well. But for the vast majority of providers, they're somewhere along that 6 incentive path. If you have demonstrated meaningful use in a prior year, it is a full year of electronic clinical quality measures. Note that I did say electronic. In prior years, 2017 and earlier, we were able to manually key in your clinical quality measure data. As of last year, that changed for the 2018 reporting year. You now have to report them electronically. And I will talk about that a little bit more on slide 26 when we unpack the skimmer program. So here is a list of the 8 objectives and that make up stage 3. If you grab the electronic PDF copy of this slide deck, which is available in the handouts section of your GoToWebinar interface, each of these hyperlinks on your screen right now will open up the objectives specification sheet. It's a great source of information to kind of understand these measures if you're not very clear on what it is you're trying to achieve and what those thresholds are. Following this slide, I'm going to try to unpack each one of these objectives. I have created, what I've tried to do is create this kind of one-stop shop where I give you as much of the kind of relevant information on the measure as I can. For the first 4 objectives, I'm able to fit what I needed to on one slide. From objectives 5 and on, there is so much information behind these objectives that they are going to split onto 2 and even 3 slides. But for each one of them, I've listed the objective, the measure, threshold if it exists, numerators and denominators if they exist, exclusions if they exist, and then I've also taken it one step further and tried to provide a little bit of guidance on what type of documentation you need to keep in your audit file, so that if you do get audited, and a lot of you are going to get audited, you've got what you need to be able to answer that audit. You can get audited as far as 6 years from now, so you really need to make sure that you've got that documentation, because 5 and 6 years from now, if you don't have what you need in that audit file, you're probably not going to be able to go back in time and get it. So I would urge you all, if you don't already do it, create what we call an audit file and keep that either electronically or in paper or both. Make sure that everybody knows where it is, because people change, people move on. We've gotten into working with some clients where they know that audit file was created, but then the person who created it has moved on to greener pastures, and they have no idea where that audit file is. So ensure that you create that audit file and have it saved in a place where others can access it as well. Hopefully you're still around if you get audited, but just in case. All right, so we're going to unpack each one of these objectives now. The first one being protecting patient health information. This is your security risk analysis measure. This will be an annual requirement throughout the entire program. We see that as an annual requirement on the MIP side as well. And it is really the same requirement. Each year you have to either conduct or at least review a prior SRA. There are no thresholds for this, just a yes or no, either you did it or you didn't. There's no numerators, denominators, and certainly no exclusions, nor should there be. We need everybody to be doing these SRAs every single year. Be careful of your program dashboards. A lot of the vendors will just automatically trigger a yes to this, even though your EHR has no idea whether you have completed it or not. Just having a yes on your program dashboard is not going to be enough to satisfy the auditor. You will have to show that additional documentation. If you get audited, you're going to have to not only show that you completed your annual security risk analysis, but you're also going to have to show your corrective action plan. So when you do your security risk analysis, it is invariably going to come out with a list of deficiencies, areas where maybe you don't have a policy in place or something along those lines. You're not changing your password often enough, some sort of deficiency that it will be labeled, perhaps a low risk, a medium risk, or a high risk. That's going to create this corrective action plan, this list of items that you need to be working on to improve your security. You're going to have to show that CAP as well. And not only show your corrective action plan, but you're going to have to demonstrate to the auditor that you are working or were working or have been or still are working on whatever that corrective action plan shows you. So you can't just do this SRA and put it on the shelf until next year. Whatever the SRA identifies as an issue, you must be working on it. If you hand the auditor that documentation and he can't see that you have been trying to do those continuous updates throughout the year on whatever was identified, you're automatically going to fail your audit. Don't be one of those folks. Objective 2, electronic prescribing, or ERX. We've had this measure since the beginning of the program. We have seen the threshold slowly increase. We are now at more than 60% of permissible prescriptions that are written by the clinician are queried for a drug formulary. That is an important component. So you have to make sure that you got at least one drug formulary turned on in your system. And then you have to transmit those electronically using your EHR. The threshold, again, is more than 60%. I'll pause here as well. We do still see some of the vendors they're not configuring their dashboards correctly, where they will give you the green check mark to indicate that you're meeting the measure right at 60%. If you are right at 60%, you're still failing the measure. The measure is very clearly more than 60%. Doesn't matter how much over 60% you are. It could be 60.00001%, as long as you're over 60%. But make sure that your vendor is not giving you the green light that you're meeting the measure when you are at exactly 60%, because you're actually still failing. And the state system will catch that. So I got the numerator and denominator. Those are pretty straightforward. There are exclusions, as we've had in the past as well. If you write fewer than 100 permissible prescriptions during your minimum 90-day reporting period, you can claim the exclusion. Fewer and fewer clinicians need to do that now. For the most part, the vast majority of the clinical community is doing ERX. But there is still that exclusion if you need it. Or if you don't have a pharmacy that's readily available or close by that accepts electronic prescriptions, you can also claim an exclusion. But again, we don't see too many clinicians needing to claim that exclusion either. So if you do claim the exclusion, you need to make sure that you have some supporting documentation there as well. For the most part, for the first exclusion, writing fewer than 100, the meaningful use dashboard is going to be enough, because it's going to show, that your denominator was less than 100. That's going to satisfy the auditor. But if you're going to claim the second exclusion for not having a pharmacy within reach, you'll have to show some sort of documentation there that there was not a pharmacy readily available who could accept electronic prescriptions. Objective 3, CDS, clinical decision support. You're implementing CDS interventions focused on improving performance on high priority health conditions. There are 2 measures here, and you must satisfy both of them to meet this particular objective. Measure 1 is the one we've had for some time now, where you're implementing 5 CDS interventions related to 4 or more clinical quality measures at a relevant point in the patient care for the entire PI reporting period. So you're going to have to demonstrate that those CDS measures were enabled for the entire 90-day period. And then if you're absent for CQMs related to the EP scope of practice or patient population, the clinical support interventions must be related to high priority health conditions instead. And then measure 2, you have to ensure that you have implemented the functionality for drug-drug and drug allergy interaction checks. Again, some of these measures used to be their own standalone measures, but they've over time we've seen them get consolidated. This is one place where drug-drug and drug allergy interaction checks all fall under CDS. really, those interaction checks are CDS. They're listed as two separate measures. So in all actuality, what you're doing is implementing 7 CDS interventions for this one objective. Again, this is another one of the yes-no measures. Either you have done this or you have not, or you're claiming the exclusion. There are no numerators and denominators, and there is only an exclusion for measure 2. So if you have written fewer than 100 medication orders during your 90-day reporting period, you can claim the exclusion on as far as implementing drug-drug and drug allergy interaction checks. Again, we don't see too many people claiming that exclusion, because even if they're not writing a ton of med orders, I don't know why you wouldn't want to have drug-drug and drug allergy interaction checks enabled anyway. In terms of documentation, again, be careful of those yes-no measures. That just having a green check mark on your program dashboard is not going to be enough to satisfy the auditor. You're going to have to show documentation that these CDS rules were enabled. You have to show that documentation of the relationship between the interventions you have chosen to enable and those clinical quality measures that you are reporting on. You have to get documentation of the computerized alerts or reminders or clinical guidelines, whatever it is that you are attesting to having in place. Find some sort of documentation. You're often relegated to print screens. Make sure that you redact those if they have any patient information on it, so you don't violate HIPAA. But grab some print screens that show these alerts popping up, or a print screen perhaps of the setup screen for that particular clinical decision support rule, something that's going to show that it was enabled during that PI reporting period. And then if you're claiming that exclusion, you'll have to prove that as well. But again, often the program dashboard is going to be enough, because that denominator for your med orders is going to under ERX is going to show that it was less than 100. Computerized provider order entry is objective 4. We have seen this in place for the past several years under mod stage 2, but measures 2 and 3 now bump up a little bit in that percent. So you must satisfy all 3 of these measures to meet this objective. Measure 1 is more than 60% of med orders are recorded using CPOE. Measure 2 is more than 60% of lab orders are done via CPOE. And measure 3 is more than 60% of radiology orders are recorded using CPOE. Again, make sure that your vendor is not giving you the green light that you're meeting this measure right at 60%. They must be more than 60% to achieve each one of these measures. So it's the exact same threshold for all 3. Numerators also the same. You've got those denominators listed there. And then there are exclusions, as we've had in past years as well, for each one of those 3 measures if you qualify for it. I'll also pause here and say that exclusions are always optional. Even if you can claim the exclusion, if you're actually meeting the threshold, I would just go ahead and put in those numerators and denominators. I mean, a 1 out of 1 is still 100%. So you're doing exceptionally well in that regard. So just because you've written fewer than 100 med orders, if whatever you have written, if enough of them have been done with CPOE, and you're achieving that threshold, just attest to the threshold. Don't claim the exclusion. It makes it a lot easier in terms of documentation as well, because you're not having to prove an exclusion, because your program dashboard is going to be enough then to satisfy the auditor. So exclusions are always optional, never mandatory. So in terms of that documentation then, one important caveat here is documenting the credentials of any staff members that's doing this work. So that's really easy for the MDs and DOs and even the nurses. You can just fall back on the fact that they have a license to practice in the state of Michigan. That qualifies them for CPOE. But if you have medical assistants that are doing CPOE, you need to ensure that you keep in your audit file a copy of their diploma. The only MAs that can perform CPOE are those that have gone through some sort of accredited MA school. Like in my area here, we have Everett and Ross and some great schools that are doing great work to qualify these MAs to be able to go out into the world and call themselves medical assistants. They do not have to be certified medical assistants. They just have to be credentialed medical assistants. And by credentialed, that just means that they have graduated from some sort of MA school. They certainly can get certified, and I would encourage MAs to do so. It could be good for their career, but a certification is not necessary to do CPOE. If you are claiming those exclusions for 1, 2, or even all 3 of those measures, make sure that you've got that documentation to support it. Oftentimes you can just rely on your program dashboard. That's going to show that denominator is less than 100. That's going to be enough for the auditor. Objective 5, patient electronic access to health information. There's 2 measures here again, and you have to meet both of these measures in order to meet the objective. So measure 1, for more than 80% of all unique patients seen by the EP, the patient or the representative is provided timely access to view, online, download, and transmit his or her health information. That is the patient portal measure. That's when you're providing that access to your patients, letting them know that they can sign up for your patient portal if they haven't already. You need to ensure that your administrative staff, make sure that those your check-in staff, your checkout staff, anyone else interacting with that patient administratively is offering that patient portal. There is no reason why you shouldn't be hitting 100% here. You need to just ride those administrative staff. If you are falling below this percentage, they are not doing their jobs. All they have to do is offer that patient portal to the patient, and you get to count them towards that 80% or more than 80%. I will also note here that timely access within this program is defined as 4 business days, but that is out of alignment now with the comparable MIPS measure. So on in the MIPS PI category, timely access is defined as 48 hours. So if you are participating in both programs, you could be looking at those 2 program dashboards and see, hey, I'm meeting the objective on the Medicaid PI side, but for some reason my MIPS PI dashboard is saying that I'm not meeting, or that the numbers are different. That could be because of that timely access issue. I would say that if you are participating in both of those programs, make sure that you are getting that data uploaded to that patient portal within 48 hours so that you get numerator count, not only for the MIPS side, but also for the Medicaid PI side. There is a second way now that patients can also access their data. This is new for 2013. It's one of the reasons why, or 2019, it's one of the reasons why you need your 2015 certified version. There's something called an API, or an application programming interface. It's basically a backdoor into that patient database, into the same data that's being pushed to the portal. Patients now have the option to connect to that data through other devices or other programs. There's a wealth of programs out there that all use this technology, where you can have like an app, a patient portal app that is not from your vendor, but is using that API technology, where the app can access what would normally be pushed to that portal and display it for that patient in much the same way. You have to have that enabled as well. So make sure that your vendors have that, and not only off of that, but you're going to need to make sure that that's turned on within your system as well. Get the API programming interface live. Make sure, talk to your vendor, make sure that this is enabled. So measure 2 then is using clinically relevant information to identify patient-specific education resources and providing electronic access to those materials for more than 35% of those unique patients seen during the reporting period. There's a slight change on this measure between modified stage 2 and stage 3 that I want to make sure you are aware of. Under modified stage 2, it didn't matter how you got that educational resource to the patient, you were able to provide a paper copy of that and it would still count for this measure. That is no longer the case. Paper resources don't count. You must provide electronic access to those materials in order for them to count now under measure 2 here, under stage 3. So we've got the thresholds, measure 1 at more than 80%, measure 2 at more than 35%. Got the numerators and the denominators are the same. And we'll flip now onto a second slide. This is, again, from here on in, I can't fit everything onto one slide for a single objective. We're going to bleed onto 2 or even 3 slides now. So the other half of the information for objective 5, looking at the exclusions, you can exclude from these measures if one of the following applies. If they have no office visits during the PI reporting period, the state really looks at that. They really question what clinicians truly have no office visits. I think there are still some providers, but then they often end up being non-patient facing, which it means you're probably not going to qualify for the program anyway. But if you truly have no office visits during that PI reporting period, you could claim the exclusion. And then there is a second exclusion that really looks at the level of high-speed internet access that is available within your county. No counties in Michigan qualify for that, so we can just move on from it. As of a few years ago, I think there was only 5 counties left across the whole United States that qualified for that exclusion. None of them were in Michigan. In terms of audit guidance, you need to have some sort of documentation that supports that the ability to view and download and transmit and access through the API are enabled. So you're going to have to demonstrate that all 4 of those functionalities are enabled. That documentation might include, and often does include, print screens of the portal setup that documents that all those functionalities are enabled. You could create a test patient perhaps and show through that test patient portal account as though it was the user going in. You could demonstrate there that all of this functionality was available. You should also capture a print screen showing that all of the data elements that are supposed to be there, you are actually pushing all of those data elements. I would grab the specification sheet on that if you're unclear about what data must be pushed to the patient portal if it exists in your system. But demonstrating that all of that information is available will be part of that audit guidance as well. And if you're claiming the exclusions, the second one doesn't count again because no counties, all the counties across Michigan have an adequate amount of high-speed internet access. But if you are claiming that you have no office visits during the reporting period, just know that not only through the audit, but really even as right after you submit that attestation, the state of Michigan is going to circle back to you and ask you to prove that you truly had no office visits during the reporting period before they will even say that or confirm that you have met meaningful use. Objective 6, coordination of care through patient engagement. So there are 3 measures here, but you must meet the thresholds for at least 2 of them to meet the objective. And when I say meet the threshold, I also count exclusions. It's not exactly clear on the specification sheets, but I've had a conversation with the state of Michigan. They are definitely on board with that interpretation, that you have to either meet the thresholds and or meet the exclusions for at least 2 of these measures in order to meet the objective. So measure 1 is more than 5% of all those patients that you've seen are actively engaged with their electronic health record by either viewing, downloading, or transmitting, or accessing it through that API, through that new technology, that backdoor that I was just talking about, or a combination of the 2. So it doesn't matter how your patients are accessing their own health information, you just have to make sure that they are. You need to encourage them. You can often do that through offering good features, make sure that they can send in appointment requests and appointment cancellations or rescheduling, prescriptions. They can grab their medical records through that. Make sure that you've got all that functionality that your patients are looking for, and then guide them to show them how, doing the secure messaging is a good way to chip away at that 5%, but you've got to somehow coax those patients to be using the patient portal. It's not enough that you just offer it to them, but you've got to get a significant percentage of your patients to actually be using it as well. And I know that can be a struggle in some of those patient populations. But you could even, one way to do that is to perhaps set up a dummy terminal in your waiting room. If you know that your patient population doesn't have computers or internet access at home, set up a private terminal in your waiting room and ask your patients to log in there and access their information. As soon as they access their patient portal account, you're going to get credit towards that minimum or that more than 5% threshold. Then the measure 2 looks at those secure messages. Again, as we've seen in prior years, you've got to ensure that you're using that secure messaging function that's built into your EHR. It's often routed through that patient portal. You get credit for not only sending messages to your patients regarding their personal clinical care, you also get credit for answering any secure messages that they have sent you as well. It does not have to be the actual EP that is responding or sending those messages. You also get credit for any of the clinical staff or really any of the doctor's staff or the clinician staff that are in that secure messaging portal. Any of those messages that are sent are going to chip away at that more than 5% threshold. Measure 3 is a new one. And I highly encourage you to grab the specification sheet on this one and really read through all of it, including the additional bullets that come up after some of the thresholds and numerators and denominators and whatnot that are reflected on those spec sheets. This one's kind of a wonky one. We're trying to work our way through it as well here. But measure 3 is patient-generated health data or data from a non-clinical setting is incorporated into the EHR for more than 5% of all unique patients seen during the reporting period. So there's a lot of additional data that your patients are getting from non-clinical settings. Let's say from their, if they're doing self-monitoring blood pressure, that's their own patient-generated health data. The data that's coming out of their Fitbit could be considered non-clinical data. If they're sending that in to the clinician, that would count. There's a lot of non-clinical data in even non-clinical settings that you can get that information from. There's a strange caveat here in this measure that you also need to be aware of, and it is reflected in that spec sheet. So I highly recommend you grab that spec sheet and read through it. But the patient cannot provide you this information during the patient visit. The spirit of this measure is to engage with patients outside of the regular office visit setting. So if they walk in for their patient visit, their regularly scheduled office visit, and they hand you that Fitbit data or their self-monitored blood pressure data, you're not going to get credit for it, or you're not supposed to be getting credit for it towards that 5%. It really needs to be provided outside of the regular office visit setting. Really, the patient could go out to the parking lot after the visit and send it to you there, fax it to you, email it to you, however, secure message it to you, and you'd be able to count it there. But you're not supposed to be counting that data if they give it during the office visit. Thresholds are all the same across the 3 measures of greater than 5%. We've got the numerators and denominators listed here. There are exclusions. Again, as we saw, similar to a previous one, there's 2 different exclusions here for across all 3 measures. You can exclude if you have no office visits during the PI reporting period. And then again, there's that broadband one, again, that we saw before that nobody in Michigan can qualify for. In terms of documentation or audit guidance, again, some documentation for measure 1 that supports that all those functionalities are available to the patient. You can grab those print screens or whatever you need to show that patients have the ability to view and download and transmit their information and access it through that API. For measure 2, documentation substantiating that all of the required data elements are available on the portal. So again, you can't just be offering that portal. You've got to make sure that that minimum data set is there. If you are unclear on what exactly needs to be listed, grab the spec sheet that I have also hyperlinked on this slide as well. It gives you that list of required data elements. At a minimum, it needs to be your problem list, your medication list, and your allergy list. But if other data exists in your system, you've got to be offering it here in a timely manner as well. You got documentation that supports the bidirectional messaging is enabled. So print screens of that administrative setup, redacted print screens of received messages and sent messages. Those are good ways to demonstrate that bidirectional messaging, not only can you send messages to your patients, but they also have to be able to respond or send you messages as well. Got to show that all of that functionality is working. Measure 3, documentation supporting the incorporation of that patient-generated health data insert. You get to decide how to pull that data into your EHR, but it's not enough that you are accepting that self-monitored blood pressure log from your patient. You've got to at least scan it into your EHR. That's what they mean by the incorporation of it. You don't necessarily have to pull it into the active chart. If you've got, some sort of electronic filing system or whatever that's connected to your EHR, you've got to at least incorporate it there. If you are claiming the exclusions for no office visits for any of these 3 measures, you'll need to demonstrate that. And just be warned, the state is going to question you on that because they have a hard time understanding that any providers that can qualify for meaningful use that don't also have office visits. So if you're going to claim that exclusion, just know that you're going to have a conversation with the state before they will even pay out your incentive. Objective 7, health information exchange. This is a big one. We've seen some significant changes under this. I think this is where we're going to see providers fall short if they don't at least qualify for the exclusions on it. Thankfully, we do have exclusions, but this is going to be a very difficult measure to reach this year. And I suspect if you fail to achieve meaningful use, it's probably going to be due to Objective 7. So under Objective 7, HIE, we have 3 measures. And again, this is one of them where you only have to meet the thresholds for 2 out of the 3. So you've got a little bit of wiggle room here where you don't have to hit all 3 of these measures through a combination of meeting the thresholds or as well and or claiming exclusions. You can do that to achieve the minimum 2 out of 3. But know that you do have to attest to all 3. You can't just skip one of them. So whether you're sending in numerators and denominators that don't meet the threshold or you're claiming the exclusion, you're still going to have to provide data on all 3 of these measures. Measure 1 is the one that we have been working with and really struggling with up to this point. This is where you are, when you are transitioning a patient from your care to another setting of care, you are sending that electronic summary of care from your cert and electronically exchanging it with that next provider of care. That threshold is now bumped way up to more than 50%. And I know so many of you have been struggling to hit that lower percentage that we saw under modified stage 2. You couldn't even hit 10%. You were really struggling. Now we are well over 50% of your patients have to be sent electronically. Not only that, now we have measure 2, which is you are now also, for patients coming into your care, and that's not just those transitions of care, but any patients who are truly new to the provider, meaning the provider has never seen them before. I'll pause here and say that this is not the billing definition of a new patient, where if you haven't seen that patient in 3 years, you can rebill them as a new patient. That wouldn't count here in your denominator, or it wouldn't get picked up in your denominator, or it shouldn't be. We'll see how the vendors configure this one. But it is truly new patients who the provider has never before encountered. Those are in your denominator. And from there, you need to look for, request an electronic summary of care. So measure 1, you're sending it. Measure 2, you are receiving it. You've got to be out there looking for these summary of care documents and pulling them into your EHR. And here you need to do that for more than 40% of those patients coming into your care. That one is going to be tough. Again, grab the spec sheet on this one. This one's going to be very, very important to understand. There are ways to exclude patients from the denominator, and I think that is how most providers are going to meet that more than 40% threshold here, is by taking advantage of the ability to exclude patients from the denominator. If you have done your due diligence in terms of requesting that summary of care from the provider sending the patient to you, or you have queried some sort of database of summary of care documents, we're seeing those get better and better and expanding over time. You can often get to those databases of summary of care documents through whatever health information exchange you're using. But if you have queried that HIE or some other external database of summary of care documents, and you've also requested it from the patient or from the provider who's sending you the patient, if you don't get that summary of care, it's okay, because you've done your due diligence and now you can exclude that patient from your denominator. If you don't see that option built into your software on how to exclude from the denominator, call your vendor and have them explain how that is, what is that workflow. I fear that the vendors are not going to configure this particular measure correctly. So if you can't tell how to exclude a patient from the denominator for measure 2, call your vendor and find out how to do that. Measure 3 is clinical information reconciliation. We've been doing MedRec for years now under meaningful use, but this measure has expanded a little bit now as well. And the threshold is up there. So for more than 80% of those transitions and any new patients coming in, you have to perform clinical information reconciliation that goes beyond just the medication rec that we've been doing for years. You now also have to reconcile the med allergies and the current problem list too. So we've got the thresholds there, more than 50% for measure 1, more than 40% for measure 2, more than 80% for measure 3. Numerators and denominators are laid out. There are exclusions. I'm not going to go through those in the interest of time here, but you could qualify for the different exclusions. You'll note that measures 1 and 2 again have that same broadband exclusion. I do have it listed there because it technically is in the legislation, but no counties in Michigan would qualify for that. But if you have fewer than one, if you transition fewer than 100 patients out of your care, or see fewer new, less than 100 new patients coming into your care, or transitioning into your care, you could claim those exclusions. I think, again, as we've seen in the past with a 90-day reporting period, a lot of providers can stay under that threshold of 100 patients and can exclude from these measures. Those exclusions would count as meeting the two out of 3. So again, I have confirmed that with the state of Michigan. And then in terms of documentation, again, measure 1, documentation substantiating that the required data elements are captured. Got to ensure that at the very minimum, the current problem list, med list, and med allergy list is included in the documentation that you are sending out with that summary of care. Again, if you're not sure of what all the required data elements are, because you do have to include more if it exists in your system, grab that spec sheet that's on your screen now. Also for measure 1, it's not enough to just send that summary of care document. You've got to have something called reasonable certainty of receipt by the receiving provider. That can be a very manual process, but you somehow have to verify that the clinician has received that summary of care document that you send out, that you've sent out to them. So you have to have, and that can happen through a variety of different ways depending on how you are sending those summary of care records. Perhaps a redacted print screen of those outgoing messages that indicate sent rather than failed or undeliverable. Depending on what system you're using, it might be more savvy, or it might be savvier than that, and provide some additional documentation that would satisfy that reasonable certainty of receipt. You could even call the clinician who you sent the patient to and said, hey, Dr. Bob, sent you the summary of care summary of care document. Did you receive it? If they can even verbally confirm that they have, you're able to count that in your numerator. For measure 2, again, this one is going to be difficult. I don't have enough faith in the vendors to configure this one properly, so really take a deep dive. If you're truly going to be working towards that minimum threshold for measure 2, talk to your vendor, make sure you fully understand how this one is going to work. How is the EHR going to know that you have queried at least one external source through that health information exchange functionality? I'm worried about this one, and we're in active discussions with the state, so they're also aware that this one is probably going to be sort of a mess this year as we work through the workflows with our vendors and work with our vendors to ensure that they have these measures configured properly. I just know that some vendors are going to have it wrong, so you might have to take a deep dive, but ensure that you've got the documentation you need, just that in case you get audited up to 6 years from now, you're able to prove that you did in fact meet this measure. Objective 8, we are up to the last objective here. That's the public health and clinical data registry reporting. This is relatively the same as we've seen in prior years, where you must be actively engaged with at least 2 public health agencies or clinical data registries. But the options have changed just slightly, so be aware of that. If you look through this list of measures 1 through 5, you no longer see specialized registry. Don't panic. Whatever specialized registry you were using in the past can very likely still be used here, although there's a slight caveat to that as well. But all of those specialized registries are either going to map to measure 4 or measure 5, depending on whether it is a governmental agency that is sponsoring or doing that registry. If it is a governmental agency, and I'll show you which ones here in Michigan would qualify. In prior years, they were deemed specialized registry, but it's now a registry that's run by a governmental agency, whether it's local, state, regional, national, doesn't matter as long as it's a governmental agency. Those specialized registries would now map to measure 4, public health registry. If it is a non-governmental agency that was offering you that specialized registry, again, there's a lot of specialty societies out there that are doing different registries. Those, because they are not governed or they're not sponsored by a governmental agency, would map to measure 5, the clinical data registries. So we have to ensure that you are connected to a minimum of 2. They could be from the same measure, even measure 1. We have some providers here in Michigan that also see patients in Ohio. I think probably the same up in the UP. We've got clinicians that are seeing patients in Michigan, but also in Wisconsin. If you are connected to the Michigan and Wisconsin or the Michigan and Ohio immunization registries, you could claim measure 1 twice, and that would satisfy this objective. So it doesn't have to be 2 different measures. This is another threshold. The one that doesn't have a threshold, it is one of the yes-no measures. It's sort of the honor system until you get audited here. You're just attesting to the fact that you are actively engaged. There are no numerators and denominators. There are exclusions. Obviously, this is a lot to unpack. Go through this at your leisure. I'm not going to read through all these exclusions, but just note that there are exclusions. And again, just like we saw on those other objectives under stage 3, where you have to meet 2 out of 3 and exclusions count, that's the same here too. So if none of these measures apply to you, you could claim 2 exclusions, and you would be able to have met this objective through those exclusions. Really, you're going to have to exclude from all 5 of them in order to still meet that objective. But those exclusions can count if there are no applicable registries for you to connect to. Whatever measures you do attest to, make sure that you've got the documentation that supports it. Each one of those registries is supposed to be able to provide you some sort of letter. I know that through the MAPS registry, that is still a little bit of a problem. The state is working through that. I think you will be able to generate those active engagement letters through the state's HISTR system for the MAPS registry. There's some additional functionality that's being built in. If you haven't been to the HISTR system lately, go to it now and you're going to see some additional fields related to MAPS. Very soon, I believe you are going to be able to actually print out those active engagement letters as well. So hang tight for this year. As long as you're actively engaged with the MAPS system, we should, certainly by year end, probably my guess is within the next couple of months, you're going to be able to generate those letters to make that documentation very simple. These are the state's public health registries and clinical data registries that they offer. So we've got MICR. I will pause here and note that there's a big change under the immunization registry reporting for stage 3. In prior years, it was you just had to be able to receive the immunization data into your EHR. It's now you must be at least actively engaged for a bidirectional feed. So if you have not already engaged with MICR for that bidirectional feed, it's called QBP or query by parameter is what it's called in the immunization registry world. But if you have not already at least thrown your hat in the ring to onboard for the bidirectional feed, you are not actively engaged with MICR anymore. The state is going to be making some changes. They're going to, in the HISTR system, to kick you out of production in terms of HISTR. You're not going to be out of production in terms of receiving the immunization data. So in all actuality, you're in production, but you're no longer in production that meets the meaningful use requirement. So the state of Michigan is going to kick you out of that production status in HISTR unless you have actively engaged with MICR for that bidirectional feed. They're also going to be making some changes within the system to make it very easy for you to throw your hat in the ring for that bidirectional feed. So stay tuned for more information as the state continues to enhance the HISTR website. They're going to try and make it as easy as possible for you. They don't want this to be a challenge. So they are working right now, as we speak, on creating those changes in the HISTR system to make it easy for you to onboard if you have not already done that for that bidirectional, but that is a stage 3 requirement. So we still have syndromic surveillance reporting, although that is still only an option for those urgent care providers and hospitals. We've got the cancer care reporting, birth defects reporting, pediatric oral health reporting under MITRE. Note here, MITRE is effectively orphaned under stage 3. As it stands right now, MITRE is not technologically advanced enough to be able to qualify under stage 3. In order for a clinical data registry or this public health registry to be able to be used under stage 3, it needs to be using certain specified standards for that data transmission. It must be, if it doesn't have an actual published standard like the cancer registry does, it's got to be falling back on HL7 as the means of data transmission, a QRDA, a CCDA. It has to be using one of these specified standards, and MITRE does not at this time use any of those specified standards. So if you have been using MITRE in the past to achieve meaningful use, you're probably not going to be able to do it under stage 3. So you're going to need to look for some other registries. Hopefully MITRE is able to advance to the next level and employ some of these specified standards for that data transmission, but because it is a very manual process right now, it's not going to qualify. We do have the MAP system now. That is a very popular option. And that is not just the fact that you have a MAPS login. It is you have to be connecting or connected to the MAP system for that data exchange directly into your EHR. So you can onboard from that. You can get some more information at the link that's on your screen right now. That is a hyperlink that takes you to the state's page. And then we also have the electronic case reporting under the Michigan Disease Surveillance System, or MDSS. You have to attest that you are actively engaged. You don't have to be in production. Somewhere in that path will also qualify as active engagement. We've had these same three options available to us for many years now under this objective. Option 1 is the only one that has a date caveat attached to it. If you're only going to be attesting to option 1, which is you've completed that registration to onboard with that registry, you've got to ensure that you've got that registration in within the first 60 days of your reporting period. If you find yourself being able to get into options 2, testing and validation, or option 3, production, it is okay to have not started that registration within 60 days. But as a safety net, if it's a brand new engagement with a registry, make sure that you are beginning that process within the first 60 days of your 90-day reporting period. So what must EPs do in order to, before they can claim that pH measure exclusion? First, you've got to look at the state options. Look back on slide 23, we just went through them. See which one of those are clinically relevant to you or your providers. If you're clinically relevant and you're technologically capable of onboarding, you're going to have to achieve active engagement with them. You're not going to be able to claim the exclusion for that measure. After step 1, you can fall to step 2 and look at the medical societies with which the providers are affiliated and see if they endorse or sponsor a valid registry that can be used within the Medicaid PI program. Again, if it's clinically relevant and you're technologically capable, you have to achieve active engagement with that registry. You would not be able to claim that exclusion. If through steps 1 and 2 you still can't find any clinically relevant measures, you can claim the measure exclusions for one or both of those required measures. I talked about the new state system called SCIMR for electronic clinical quality measure reporting. This is new as of this reporting year, or well, the 2018 reporting year that just closed a month or so ago. So if you attested to meaningful use in Michigan here for the 2018 program year, you're probably well versed in the trials and tribulations of the SCIMR system. What we're trying to do here, the state's trying to do, is they're trying to phase out that manual submission process of the quality measures and ultimately move towards a report once capability. So these same clinical quality measures that are used within meaningful use are also used in a variety of other programs. And so what the state is trying to achieve here is giving you the ability to submit your quality data one time and then have it parsed out to multiple programs. Right now, as of today, it's only connected to the meaningful use system. But in the future, the long-term goal is that the SCIMR system would be able to submit to MIPS for you as well, or if you're using if you're in one of the states or there's some value-based reimbursement programs within the different payers. We're all trying to align these quality measures so that you can submit it at one time, and then the SCIMR system is going to parse it out to everybody. Again, as of right now, and I don't know when it's going to expand to pick up those other programs. Right now, it's only connected to this program, but sometime down the road, it will hopefully achieve that report once capability. To submit your 2019 CQM data, the EP will need to get their hands on what's called a QRDA3 file from the EHR. I hope by year end it will also be able to accept the MIPS file type that's called JSON, J-S-O-N. Right now, SCIMR cannot accept the JSON files, and the state's eMIPS system can't accept JSON. We're working with them. We hope to have that ability sometime later this year, but as of right now, it has to be a QRDA3. You got a link to the state's announcement if you didn't see that when they sent it out last year. And then I've got a link to the actual SCIMR site as well, to where you can register and test your files. The state's going to require that you at least attempt to submit your clinical quality measures. There's a lot of reasons why that might not be able to happen. A lot of vendors are still struggling to create these QRDA3 files in a format that the SCIMR system can accept. But you've got to at least try that. If you try and fail, you can request what we call enable web or break the glass functionality, where the state on a NPI by NPI basis will go back and enable that manual CQM data entry. What else do you need? I'm going to cruise through these. I know we're getting to the end of the time here. When you go to a test, there's some other information you're going to either want or going to need to be able to test, or at least keep in your audit file. Obviously, those attestation reports and files, whatever your dashboard reports are, your CQM reports, your QRDA3 files, you're going to make sure that you keep copies of all of that. You're going to have to upload your dashboard reports as well at the time of attestation. Also, in terms of proving that Medicaid program eligibility, anyone who has been participating in this program knows that that can be a rather laborious process to get through that step, but you're going to have to not only attest to that Medicaid eligibility threshold of more than 30%, but the analyst is going to circle back and try to audit the information that you upload against the Medicaid database. Again, that can be a rather back and forth laborious process. You can help that by ensuring that you are uploading the right Excel files, those reports that show the total encounters, shows the total Medicaid encounters, and make sure that they have all of these data elements as well if possible. Proof of certified EHR technology. We all have to be using our 2015 certified technology this year. Make sure you keep something in your audit file that, such as a copy of the purchase agreement or some sort of communication from the vendor that denotes that you are on that 2015 technology, vendor name, product version. The 50% rule doesn't come into play as much as it used to in the past because so many clinicians are now on certified technology. But if you have to meet the 50% rule, which is proof that at least 50% of the patients seen during your reporting period were seen at locations that have certified technology. So if you are a clinician that works at 2 sites, one of them has certified technology and one that doesn't, you have to ensure that more than, or that at least 50% of the total patients seen by that clinician are seen at locations that have certified technology. So you're going to have to show that documentation as well. The DCH 1401, if you don't already have this on file, a lot of you would have it on file for your billers, but you'd also need it. It kind of authorizes, it's the authorization if you are acting on your clinician's behalf to complete their attestation. It's just the authorization from the EP that you can act on their behalf. So if you don't already have that filled out and in your audit file, you want to do that. If you're practicing in FQHC or RHC, if you're using your needy individual populations, you're going to want to have that documentation as well as practices predominantly, if that's applicable. And if you're in a PA-led location, FQHC or RHC, you're going to want to have that documentation that supports that as well. Got a wealth of resources here that can overwhelm you, I know, but really everything that I've talked about today is reflected somewhere within this mass of resources, including the Skimmer website down there at the bottom as well. And with that, I will look at questions. I think we only had 2 that have come in throughout this session, and I think one of them I have already answered. The first one was, when will the state give us evidence of active engagement in the MAPS registry? If you need to, you can just rely on that documentation you're getting from APRIS. That's the third-party vendor that's connecting your EHR to the MAP system. There will often be some back and forth with the APRIS folks. You can use that email if you need to attest now. But just note that they're actively working on that. We know that this was a problem for 2018. The state is working with MAPS. They're making changes to the HISTRA system. So I think within the next couple of months, probably, you'll have that ability to generate those active engagement letters, much like you can do for MICR and the other state registries. Under MICR, if you are still working on the unidirectional feed, can we throw our hat in for bidirectional? And how do we request active engagement on bidirectional? Great question. So yeah, your unidirectional feed is not going to change. That's not going to be taken offline. They're gonna work with you to create that bidirectional feed, and you don't have to be live on the bidirectional feed as long as you're actively engaged in it. As of right now, the only way to request that active engagement on bidirectional is just to reach out to MICR. There's a wonderful lady there by the name of Sally Sims, who's kind of managing this whole process. At this time, the only way that I know of to request active engagement on that bidirectional feed is to reach out to Sally Sims and make that request. Again, the state is formalizing this. They really want to make this as easy as they can. So very soon there will be an option built right into the HISTR system that will be like a checkbox or a button that says, you know, this location or this provider wants that bidirectional feed. The idea being you can just click that button, and that would at least give you that option 1 of active engagement. If you need Sally's email, you can request it from me, the person that just pinged me via the chat box. Yes, after this, I will email you Sally Sims' email address. With that, I'm a couple minutes over, as I usually am when I go through this slide deck. My apologies. If you have any other questions for us, please don't hesitate. We are here to help. We are also still subsidized by the state of Michigan to assist you in your efforts to achieve meaningful use. I know a lot of you felt you knew what you were doing under modified stage 2, but as you've probably just figured out, stage 3 is a bit of a beast. And just because you have achieved meaningful use up to this point doesn't mean you're going to continue to achieve meaningful use from here on out. I think a lot of clinicians are going to fail meaningful use because of these significantly increased thresholds and workflows. If you need help, the state is paying us to be out there helping you. Without the state's help, our help could cost you anywhere from $5,000 to $6,000. With the state's generous subsidies, it costs you only $200 per clinician. So give us a call, email me, website's there with information. The 888 number gets to my team of colleagues that are ready to help you as well. You can ping me directly if you want to talk about that subsidized support, but that would get you one of my my talented colleagues can work right with you in your office and they've got a wealth of expertise on these measures in terms of best practice, tools. They can guide you through every step of the way. For only $200, we're going to work tirelessly to get you to that $8,500. So it is a great deal that I hope you'll take advantage of if you are not already. With that, I thank you for joining me today, and I look forward to seeing you on future webinars. Have a good day.